There is a disease that killed 30 out of every 100 people it infected. It destroyed entire families. It blinded children. It left survivors scarred for the rest of their lives. The United States government responded by developing a vaccine and deploying it steadily over decades until the disease was wiped from the earth completely. Then there is COVID-19, a disease with a death rate below 1% across the general population. The response this time was different. Governments closed schools, closed businesses, deployed Navy hospital ships to major cities, spent trillions of dollars, locked 2 billion people inside their homes, and then reached back to a 1905 Supreme Court ruling, a ruling written specifically about that first disease, to justify forcing the vaccine on soldiers, federal workers, and hospital staff. Same legal framework, different disease, very different numbers. What smallpox actually did. Smallpox was caused by the variola virus. Two main strains existed, variola major and variola minor. Variola minor was the milder form, with a death rate around 1%. Variola major is the one that defines the historical record. Variola major killed approximately 30% of the people it infected, 3 out of 10. The disease began with fever, back pain, and vomiting, then erupted in pustules across the skin, including inside the mouth, throat, and on the eyelids. In severe cases, the lesions merged together across the entire body. Roughly 1/3 of survivors lost partial or total vision. The scarring was permanent and often severe. The numbers over time are staggering. According to the World Health Organization, smallpox killed an estimated 300 million people during the 20th century alone, not across all of recorded history, just the 1900s. For context, World War II killed approximately 70 to 85 million people. Smallpox killed roughly 3 times that figure in the same century, without a single battle being fought. Children were hit hardest. In some outbreaks, infants had mortality rates between 80 and 98%. The disease moved through populations with no regard for borders, age, or wealth. Queen Mary II of England died from it. Abraham Lincoln contracted a mild form immediately after delivering the Gettysburg Address. Native American populations were devastated by it during European colonization, with some communities losing over 90% of their people in a single outbreak. Smallpox spread through direct contact with an infected person, through contaminated surfaces, and through respiratory droplets during close contact. The incubation period ran between 7 and 19 days, meaning infected people moved through communities before they had any visible symptoms. The last naturally occurring case was recorded in Somalia in October 1977. A hospital cook named Ali Ma'au Malin survived. The WHO declared smallpox eradicated on May 8, 1980, making it the only human disease ever fully eliminated from the earth. What made that possible starts in a Cambridge, Massachusetts courtroom in 1905, the court case that set the standard. In 1902, Cambridge, Massachusetts was dealing with a smallpox outbreak. The city board of health issued a mandatory vaccination ordinance. A pastor named Henning Jacobson refused to comply, arguing the government had no constitutional authority to force a medical procedure on an unwilling person. The case reached the United States Supreme Court. In 1905, the court ruled 7-2 against Jacobson. Justice John Marshall Harlan wrote the majority opinion. The ruling did not give states unlimited power over the bodies of their citizens. It said something more specific. States have the authority to enact reasonable public health regulations, but those regulations cannot be arbitrary, oppressive, or unreasonable. The severity of the threat had to justify the intrusion on individual liberty. The court was deciding this question against a disease with a 30% kill rate. That was the baseline. That was the threat level the justices were looking at when they concluded that, yes, under these circumstances, a mandate can be justified. The ruling also acknowledged real concerns about vaccine safety. Jacobson argued his family had suffered adverse reactions to vaccinations. The court did not dismiss that. Harlan's opinion included limiting principles specifically to address people who could show that vaccination posed a particular danger to them. One detail most people skip past: the smallpox vaccine at the time was not perfect. It carried real documented risks. There were known cases of the vaccine itself causing serious harm. The court was fully aware of this and still ruled that the threat of the disease was severe, enough to justify the mandate anyway. That tells you exactly how high the court set the bar. Jacobson versus Massachusetts, 197 U.S. 11, became the foundational legal precedent for government authority over individual medical decisions in the United States. It sat largely in the background of public health law for over a century. Then 2020 arrived, and the legal architecture built around a disease that killed 30% of patients got applied to something with very different numbers. COVID-19 by the numbers. The COVID-19 pandemic was declared by the World Health Organization on March 11, 2020. The disease was caused by SARS-CoV-2, a novel coronavirus first identified in Wuhan, China in late 2019. Early death rate estimates were high because testing was limited and only the sickest patients were being counted. As testing expanded and more data came in, the picture changed significantly. The infection fatality rate, meaning the percentage of all infected people, including those with no symptoms who died, settled at approximately 0.1% across the general population. This figure comes from data published by the CDC and a widely cited meta-analysis published in the European Journal of Clinical Investigation in 2021 by Dr. John Ioannidis of Stanford University, which estimated a median infection fatality rate of 0.15% globally. Broken down by age, the numbers diverge sharply. For people under 50 with no serious underlying health conditions, the infection fatality rate was closer to 0.01%. For people over 70, particularly those with conditions like diabetes, heart disease, or obesity, the risk was substantially higher. The CDC estimated the median age of COVID death in the United States at approximately 75 years, which at the time was slightly above the average. American life expectancy of 74.2 years for males. That is not a dismissal of the people who died. COVID-19 killed over 1 million Americans. Those were real people with real families. The point is proportion. Who was at risk, by how much, and whether the response matched that reality. There is also the question of how deaths were counted. The CDC itself acknowledged during the pandemic that COVID was listed as a contributing cause on death certificates even when the primary cause was something else entirely, such as a car accident or a pre-existing terminal illness, where the patient also tested positive. Some researchers and physicians argued publicly that this inflated the headline death numbers. That debate has never been fully resolved in public. It was largely treated as misinformation rather than a legitimate statistical question worth examining. Smallpox carried a 30% death rate. It killed children, young adults, and people in the prime of their lives with no underlying conditions. No age group was spared. COVID-19 carried a 0.1% overall death rate. The risk was concentrated heavily in people over 70 with pre-existing conditions. The survival rate was above 99% for most. Healthy adults under 60. Both diseases triggered government mandates. Only one of them justified the legal standard. Those mandates were built on.
So how is it that COVID-19, the virus, how does it actually kill people? What is the pathophysiology, the processes that are at play that result in someone dying? First, there's actual destruction of lung tissue. The virus destroys cells in the lungs. It causes damage to the structure of the lungs, the architecture of the lungs. That can be irreversible. The patient cannot recover. And sometimes it causes such deep scarring that if they do recover, they have long-term disability with their lungs. Severe COVID-19 can also cause a hyperinflammatory response, or something that's also known as cytokine storming. For a long time, before COVID-19, I was always skeptical of the diagnosis of cytokine storming. I thought it was kind of a hand-waving term. It didn't have a lot of evidence to back up that it was an actual phenomenon. But I'm convinced, and now everybody else is, that cytokine storming is definitely happening in patients with COVID-19 with severe disease. And it is a dysregulated hyperinflammatory response that the body has, that they're reacting to the infection of the virus. This cytokine storming, which is like a positive feedback of the immune system, can ultimately cause multi-organ failure, critical illness, and death, and it does in severe COVID. This is why steroids can be helpful and reduce mortality in severe COVID. It stops that inflammatory response from taking over the body. Another reason that COVID-19 can be deadly is it causes clots. There are many reasons that a patient with severe COVID-19 is prothrombotic or can get clots. It can have to do with destruction of blood vessels in the lungs from the virus. Being in an inflammatory state can make you prothrombotic. Getting something called DIC, disseminated intravascular coagulation, which can result from critical illness. All of these things just create the perfect storm where clotting can happen. It can be very deadly. It can affect the lungs, it can affect the heart, and it can affect other organs as well. And then, of course, the main reason that COVID-19 is deadly is that it causes ARDS, acute respiratory distress syndrome. This is where you get destruction of the lungs, like I mentioned before. You get fluid filling the lungs, you get immune tissue filling the lungs. You can't oxygenate the lungs anymore. You put in a breathing tube, you try to mitigate with that, and then sometimes these patients ultimately need to go on ECMO with the hope that their body will recover.
This map shows how COVID started spreading across the world. December 2019. The first known cluster appears in Wuhan, China. Doctors report a new pneumonia-like illness linked to a seafood and live animal market. Within weeks, cases start appearing across Hubei province. January 2020, people travel. Flights leave Wuhan for Bangkok, Seoul, Tokyo, and Singapore. The virus crosses borders before the world even knows what it is. By mid-January, cases reach Europe. First France, then Germany and Italy. Northern Italy becomes the first major outbreak outside Asia. Hospitals overload. Lockdowns begin. At the same time, the virus arrives in the United States. The first confirmed case is reported in Washington state. Then clusters appear in California and New York. February to March 2020. Global spread explodes. Iran becomes a hotspot in the Middle East. Spain and the UK surge. New York turns into the world's epicenter. By March, COVID is on every continent except Antarctica. Borders close. Flights stop. Cities locked down. What started as a local outbreak in one city became a global pandemic in just weeks.
The ships that treated almost nobody. In late March 2020, the USNS Comfort, a 1,000-bed naval hospital ship, arrived in New York Harbor. Cameras were everywhere. The governor called it a tremendous help. The coverage was extensive. The symbolism was clear. The country was at war, and it was fighting back. The Comfort treated 182 patients before departing. 182 on a vessel designed for 1,000. The USNS Mercy was deployed to Los Angeles with the same framing, an overwhelmed city on the edge of healthcare collapse. In its first 2 weeks of operation, it treated fewer than 80 patients. It was eventually reassigned. The Javits Convention Center in New York was converted into a field hospital. Thousands of beds, National Guard deployment, full federal coordination. At its peak occupancy, it held fewer than 500 patients before being stood down. Pre-positioning resources ahead of a potential surge is defensible emergency management. Nobody disputes that. The harder question is what the actual data showed when the surge arrived, and whether the narrative delivered to the public matched what was happening. Inside those buildings, nurses and doctors at multiple hospitals posted videos in early 2020 showing quiet corridors, some footage that circulated on social media and was shared by verified accounts as current scenes from overwhelmed hospitals was later found to be misrepresented, including footage from Italian hospitals shared with captions attributing it to New York City. Those questions were not answered publicly. They were removed from platforms. The pattern is worth sitting with. A legal framework designed for a 30% kill rate. Ships deployed to cities where they treated a combined 262 patients, and public conversation about the actual occupancy figures shut down rather than engaged. And all of that was happening while the economic damage being done to ordinary people was accelerating every single day. What the comparison actually shows: smallpox killed 300 million people in 1 century. COVID-19, with a full global population of nearly 8 billion and modern interconnected travel, killed approximately 7 million people worldwide as of 2023, according to WHO figures. That total is roughly equivalent to what smallpox killed every 2 years during its worst periods in the 20th century. The response to smallpox was a vaccine. It was developed in stages from Edward Jenner's cowpox discovery in 1796, refined over the following century, and deployed through a global eradication campaign that ran from 1967 to 1980. During that entire campaign, economies stayed open, schools stayed open, businesses stayed open. The response to COVID-19 involved a $2 trillion spending package passed in a matter of days, school closures lasting years in some districts, business closures that permanently ended millions of small enterprises, and vaccine mandates applied to military personnel, federal employees, and healthcare workers. All of it was legally justified by invoking a Supreme Court case decided in 1905 about a disease 300 times more lethal. The Jacobson decision itself contained the answer. Justice Harlan's majority opinion explicitly tied government authority to the severity of the threat. The standard was not blank check power, it was proportionality. The more dangerous the disease, the more justified the intrusion. By that standard, the case for mandates was ironclad in 1905. Applying that same case in 2021 required ignoring the very logic the 1905 ruling was built on. The downstream consequences of the COVID response are also now documented. The CDC reported a significant increase in drug overdose deaths during 2020 and 2021, with over 100,000 overdose deaths recorded in the 12-month period ending April 2021, the highest single-year total ever recorded in American history. Mental health emergency room visits for children and adolescents increased sharply during school closures. The learning loss recorded in American schools during that period, particularly among low-income students, is now described by education researchers as generational. These were not minor side effects. They were predictable consequences of the decisions made, and they fell hardest on people who had almost no statistical risk from the disease itself.
What if the World Health Organization had failed to eradicate smallpox in 1980, leaving this killer virus circulating when COVID-19 struck? Smallpox kills 30% of everyone it infects. That's 10 times deadlier than COVID. Over the past 4 decades, it would have claimed 300 million lives, with children being the most vulnerable victims. Now imagine both viruses spreading simultaneously through modern air travel. Passengers boarding flights in London, Tokyo, and New York, unknowingly carrying 2 different plagues across continents. Every hospital on Earth would have collapsed within weeks. Social media would explode with deadly misinformation about treating both diseases at once. Vaccine hesitancy would have killed millions more as people refused protection against either virus. The death toll would be beyond comprehension. We're actually living in the best possible timeline. Smallpox was eliminated just decades before global travel could have made it unstoppable. One successful campaign saved our modern world from unimaginable horror.
The verdict. Smallpox wins. It is not close. It is a category difference. Smallpox blinded children, ended civilizations, and killed 300 million people in a single century. The eradication of smallpox in 1980 is listed by the WHO as one of the greatest public health achievements in human history, because the magnitude of what it used to do was that significant. COVID-19 killed real people and deserves to be taken seriously. A 0.1% infection fatality rate affecting 8 billion people still produces a large number. Nobody is arguing otherwise. What this comparison actually shows is a question about proportion. The legal precedent used to justify COVID mandates was written for a disease 300 times more deadly. The emergency powers invoked in 2020 were powers designed for catastrophic, all ages, no escape scenarios. The ships went to cities and sat mostly empty. The field hospitals were stood down. The footage circulated online was misrepresented, and the people who pointed that out in real time were silenced rather than answered. Smallpox got a methodical decades-long vaccine campaign and eventual eradication, with no economy closed and no school shut down in the process. COVID-19 got $2 trillion, locked down cities, empty hospital ships, over 100,000 overdose deaths in a single year from the fallout, a generation of children with documented learning loss, and a Supreme Court case from 1905 dusted off and applied to a disease that the justices who wrote that ruling would not have recognized as meeting their own standard. The math is not complicated. The history is not hidden. We stopped the world for that. If this breakdown scratched something for you, the next one goes even deeper. Subscribing and turning on notifications is the only way to catch it when it drops.